Welcome to COVID-19, the Orthopaedic Response. I am Stefano Bini. I am the host of this conference, and I'll be host today anyway, and part of the DOCSF team, Digital Orthopedics Conference San Francisco team at the University of California, San Francisco. And we're thrilled to be joined by the American Academy of Orthopedic Surgeons as a global convener to address and rapidly respond to the dramatic changes to healthcare patients in our communities. We're grateful to have a global audience joining us in this discussion. And I'm extremely pleased to invite Dr. Michael Blum from UCSF. He's the Associate Vice Chancellor for Informatics and the Chief Digital Transformation Officer at UCSF. He's responsible basically for UCSF's strategic design and implementation of informatics and digital health capabilities in support of the clinical care we deliver as clinicians. He's also a professor of medicine and cardiology and passionate about wellness and the prevention of heart disease through a heart-healthy lifestyle. And Michael, it's so great of you to take time. I actually know exactly how crazy your life is right now, so you taking time out to speak to us is a real honor. Thank you.
Sure, Stefano. Thanks very much. Pleasure to be here with you all. I actually see some friends sending hellos already.
Awesome.
Yeah. So again, thanks for allowing me to be part of this. It's a great event. Stefano, we've been doing this since the first DOCSF.
That's right.
Event.
That's right.
Yeah. And it sounds like it's grown tremendously. So congratulations for that.
Thank you.
So I guess just to do a little level setting, let me talk a couple minutes about the Center for Digital Health Innovation, and then we can kind of segue into the current crisis and where we are, if that's all right.
Absolutely. So actually, Mike, before you start, for the audience, just for the audience, because they don't know what we asked you to talk about. What we asked you about is a challenge that you're going to have, or you have as an enterprise, to deploy technology very, very quickly within the context of a crisis situation. And you're at the forefront of that. You're leading that change. So I want to hear the challenge you've had in that context. And we're going to frame it, we'll hear about CDHI, which is this amazing infrastructure you've built. And also, so we're going to see two parts of it: what you'd recommend for a smaller group, and how you see the challenges for a larger institution like University of California looking at these technologies. So now back to you, and I'll get out of your way.
No, I think that's great, because I think those are all tied together, and it'll make a little bit more sense if we kind of go back a couple of years. About 6 years ago, we started the Center for Digital Health Innovation. And you can think of it as kind of the enigma of running a startup in a huge university. So we're about a $10 million a year business running inside a $7 billion a year enterprise. And as most of the folks know, big academic centers are very slow to move, very slow to change, and to adopt new technology is very difficult. So we take that responsibility at the Center for Digital Health Innovation of how do we drive out these new technologies. And we work with partners all across the technology space. We work with very large, very traditional partners like GE and Philips, all the way down to startups in the space that we've worked with, several of them to implement new technologies at UCSF and help them do that beyond in the Bay Area. Our model is that we started with a small startup funds from the Chancellor's office. And since then, there's been no ongoing funding from the university. Everything that the center creates is off of partnerships with industry and licensing deals from technology we built. So we work with internal innovators to find technologies, build them out to proof of concept and pilot in the clinical environment, validate them, and then spin them out and have external partners build them out and market them globally. And we've licensed technologies, again, out to GE and out to smaller companies like Volt, who does hospital communications, and all across the spectrum. So we've done that. It's been really interesting and really exciting, and we've learned a lot over the 5-6 years. And I think that we're at a point now where that really the timing is good coming into this crisis, and especially to talk about how we come out of it. The other piece that has happened just the way things always happen is, coincidentally, we were finishing one of our strategic plans, our 5-year strategic plans at UCSF, and beginning the next 5-year strategic planning process. And the environment recognized that digital technologies had become incredibly important to the future success. And digital transformation actually became one of the 3 pillars of the UCSF 5-year plan. So embracing digital technologies, digital transformation, innovation at scale is all part of the 2020 through 2025 strategic plan at UCSF. So I co-lead that with our CIO, and it's all about how are we going to transform our business. It's called digital transformation because that's the sexy thing now, but it really is about business transformation using data, using digital technologies, and how do you do things at the speed that consumer organizations do now. If you think about it, no one goes to rent a DVD anymore. Everyone streams everything. Banks were first with moving to ATMs. There aren't even ATMs anymore because you can do everything online. How do we get healthcare to that point is a big part of our mission right now. We also do a lot of AI development, and we've just successfully licensed one of the first on-machine chest X-ray apps to GE, who's deploying that across the world actually to look for ICU critical conditions like pneumothoraces and things like that. So we really span a broad spectrum of innovation. I think that the issue of digital transformation is particularly important, and it plays into this discussion really nicely because everyone thinks of it as just putting a bunch of digital apps in, moving things to the cloud, and those are certainly pieces of it. But what's critically important is that you build a different operating model and you build the infrastructure in your organization to think differently. You can't think of every new vendor who comes in as putting another project in space. You have to start transforming your thinking to product-based thinking, as is done in much of the consumer world. And you really have to change from how do we put things in that work for our ORs, work for our schedulers, work for our clinicians. You have to start thinking about product and how does that work for the consumer? How does that work for the patient? How does that work for the family? And look at those as end-to-end consumer journeys, or sometimes they're called consumer stories. And the whole thing broadly is called user-centered design. And you combine that with agile technology, so we get out of the old slow builds that we had with the EHRs, and we move into contemporary technology stacks and contemporary builds, so we can change things up much, much more quickly. Example, in the current crisis, the Department of Health came in one day and they said, there's COVID running around here. You now need to screen every employee who goes into your building for potential COVID exposures before they can go into the building. So the organization did what everyone does, came up with a list of questions that we had to ask everyone, and then we asked everyone all the questions as they came to the front door to go to the building. Well, not surprisingly, that made lines of hundreds of people trying to get into the building. So using our new infrastructure and capabilities, within 5 days, we had built and deployed an online screening tool that all the employees could do at home or on their way in, do it on their phone, then just kind of like a TSA pre-check, show their phone to the screener, and away they go into work. Those are the kind of things that historically took weeks and months to plan and do that we were able to stand up in a week in the middle of a crisis. Go ahead.
Let's talk about that infrastructure required to make that happen quickly, and what part of that could reflect the lean methodology. So for those people who may not be aware what that actually is, but I think that sounds like a great story to tell, so people understand what an organization that has been planning and putting in place infrastructure can do in a situation like this. Of course,
Right.
That being a lesson for the future for people who need to start thinking about putting those things in place. So what does that look like? How does that play out?
So I kind of alluded to some of the pieces of it, and some are vendor pieces, which I'll touch on. But the first thing you have to do is you have to get out of the thinking of, okay, this is occupational health issue, so let's go ask the occupational health people, and then let's get the regulatory people who know what the algorithm needs to look like. Let's get them together and ask them, what we should build. And then you get a project manager who starts working on it and does all the technology stack. That's the old way we would have done it. The new way is you have an agile team, which is interdisciplinary, which has technologists on it, has user-centered design folks on it, and then it grabs the people who are the subject matter experts and brings them all into a room and says, okay, describe the user journey for me. What is this all about? And in this case, what it's about is an employee trying to get into work and needs to answer a bunch of questions. And that data for the ones who have specific answers needs to flow into the occupational health work streams so that they can deal with it. And you start with it from, okay, that's going to be the user journey. What's the problem we're trying to solve? And the problem isn't, oh, occupational health has to find these patients. The problem is people need to get to work. People need to get into the building. And so how do we get them through those pieces? And so we had the tool, we had the muscle, so to speak, in place that we knew how to get those teams together. We knew exactly who the people were. We had the designers, we had the UX experts. We already had the stack with the cloud that we could stand up and proof everything immediately. And by the end of, day 1.5, we already had pilots running, prototypes running. So the other piece is then you need someone who's going to, be able to deploy it, support it, and scale it to multiple locations. And in this case, we were already working with a vendor around patient-reported outcomes who had a lot of experience. And as we built and prototyped, they were able to move, to port that to their platform so it could stand up and have the performance that we needed to go ahead. So shout out to Conversa, who's a young startup. Am I allowed to do that? Can I do shout outs to vendors here? I'll keep it small. So they were fantastic, and we had the whole thing stood up in a week, and it's been up with essentially zero out time. We went from the thing not existing to screening 3,000 employees going through the doors a day. They were taking about 2 minutes, 3 minutes to go through the screening process initially. Now it took 8 seconds for them to go through the screening process. So I'm not hearing you, Stefano.
Thank you for saying that. I muted myself to avoid the background noise for you.
I thought it was supposed to be lip reading.
Yeah, well, that's next gen. So what I say is that the way it works on mine as an employee is that I have a questionnaire, a chatbot questionnaire that comes through, basically runs me through the COVID platform. I then hit done, and then it puts a screen up on my phone, which I can then show to when I walk in the door. Right. And the screener just looks at it, 8 seconds, you've gone through the screening session, boom, you're done. And this, of course, is recorded in the cloud and tracked. And so that was the idea, right? How do you solve, this is design thinking. And you may not know, IDEO is in the process right now, and soon after we're done, we'll be doing exactly that kind of protocol process to try to design think around some solutions like that. It's fantastic. The fact that in a day and a half, you guys had a prototype running, and again, to just remind people of what that process looked like, you brought all the key stakeholders in the room who had the appropriate knowledge base, took all of the responsibilities away from them so they could focus on that task, gave them a whiteboard, gave them the time and the resources necessary, and they just went to town and came up with a solution and tested it, right?
Yeah, and it's been really a fascinating journey because, 3 years ago, we were just like everyone, we, bought stuff from vendors and followed their instructions to put it in, and we sat there and tweaked. The concept of product managers, not project managers, design experts, design thinking was all relatively foreign to us. And it's been a real fantastic learning experience combining the lean methodologies along with design thinking, how much more quickly you can stand things up and how much less rework you have to do as you go through these things by starting with these interdisciplinary teams and knowing what, understanding your goal. It's really fantastic, and it's been a great change for us. It's been interesting also to watch as these people who know very little about healthcare actually go out into the healthcare space and are immediately told you don't know what you're talking about because you don't know healthcare, and no one wants to listen to them. And then as they build the relationship and people start to say, oh, well, that is interesting, maybe that is a better way of doing things, or they start asking questions about why do you do it this way? I don't understand why you would make your patient sit there and doing nothing or re-enter something. All the things that patients and consumers complain about, they start poking at those, and it's just incredibly refreshing. The other piece that is relevant, to this discussion is, so we built this thing and we just built it out of our own need, but now we're looking at how do we deploy this around the Bay Area to our affiliates and get them out of this mess. And it's gonna, the other UCs are looking at how do they take it up, and then the company is building it into is already built it into their platform and gets to offer it globally. So it's nice to see these things that we just build out of immediate, quick need can then get disseminated without everyone else having to try to redo it.
tell me a question, because I'm curious now. How has that impacted the perception of the work the CDHI is doing at the university level? Has the fact that you've been so successful now opened doors for you that perhaps in the past were maybe a little bit not fully open?
Yeah, I think that's definitely true. So historically, we worked, a little bit in a cave, and we're a little quiet. And even when we came out with the work that we did with GE that they're licensing at, it was still not something that people locally could really touch and feel as much. We started working in the self-scheduling place, and that stuff went up in pilots, and did a lot of work around referrals management, and that was out there. So small pieces of the organization started to get to see our work and started to say, hey, this is really, a much better way of doing these things. But it was really in small pockets. This is the first time that in the middle of a crisis, our teams stepped up and said, hey, we can do this. They knocked it out of the park. And I think that's going to lead to one of the things we want to talk about is, how do you come out of this? Bless you.
Thank you.
How do you okay there? You're not going to start coughing and get a fever or anything.
No, I think
no, there you go. So this gets to the point of, okay, the more we do of these kinds of of developments and quick implementations that work well, the more we get to be in a place where we say, hey, everyone's appropriately focused on this crisis right in front of them. I mean, this is right in front of everyone, and everyone's working to take care of the today problems, the tomorrow problems. The big problems that we look at are, at some point, things are going to change, and we're going to start figuring out how to try to work out of these. So good example is, we've basically closed all of our outpatient offices, and we've gone from seeing 1% of our patients on video, using video visits. We now see over, now it's almost 60%, 55, 60% of our visits are delivered via video right now.
Across the whole system.
Across the organization, yep. So, we were doing 10,000 visits a day. Majority of those got taken out immediately because of rescheduling. Well, now we're trying to bring the schedule back up and do them via video. So huge volume of video visits that didn't exist before. So we needed to quickly move from the old model to a new model, which is great. But as you think about the future, that's not going to go away. This is now kind of an entitlement in a way. People will say, hey, I can have a doctor visit without having to go wait in their smelly waiting room, without having to go drive to the office and have horrible parking, without having to wait for an hour. People are going to want video visits. So they're not going away. So similarly, there are going to be other things that we're going to have to really, really plan for. And one of the biggest of them is, we're postponing hundreds of thousands of encounters, and those might be doctors, they might be office visits, or they might be imaging studies and referrals. So when we start thinking about how we're going to dig out of this mess, we're going to have hundreds of thousands of those, and there's no way they're going to work the old way, which would have been, call the office to reschedule, right? There'll be, weeks worth of waiting on the phone, and no one's going to do that. And the ones we want, who have a choice, will go to our competitors. So we've got to put in new tools, which we've been working on for a while, self-scheduling tools, chat bots, virtual care platforms, all those which were planned to go in over a period of years, now are going to need to go in over a period of months. And we need to start doing it now, because we can't wait until, the crisis is over. There are hundreds of thousands of scheduling events. How are we going to do it? That will never work. So we're starting to think about doing the planning, building the infrastructure to do that right now.
That's a really important lesson you just shared with us, is this idea that not only are we going to get back to a new state that's not going to be the same as before, but if we don't plan for it ahead of time, we may be caught flat-footed and not be able to respond to the demand in the way that patients want that demand to be responded to, right? And
so it's not only to be able to respond, but it's to think what the world is going to be like that you're going to need to be responding to, right? So, most people are just looking at the crisis. They're like, okay, well, these people are going to start calling, and then we'll do the rescheduling. We'll move the people back into the call centers, and then we'll do the rescheduling. Like, that is not going to work. This world is going to be completely different when we get there. The volumes are going to be unimaginable of people needing care and wanting to reschedule things. And they're all going to be scared, and they're all going to be very unhappy, and they're not going to be wanting or tolerating the kind of weights they did before. So we really need to move to newer technologies and newer capabilities make this stuff happen.
Let's do a quick shift. If I was an innovative group, small group, 20, 30 person group, something like that, I'm not the university, I don't have the infrastructure in place, how would I think about deploying new technology in a time of crisis?
So it's a great question, and without all of the resources to do the baseline assessments, we spend a huge amount of time going through the companies who say they do things in the spaces, and everyone's got a real glitzy website and tells you how they understand the problem, and they have all these tremendous metrics of how they've reduced stays, how they've increased your profitability, how they keep people out of the ICU, prevent unexpected, unanticipated returns. So it's really hard. I'm very sympathetic to the smaller groups trying to pick which vendors and which products are real. That has been magnified, I'd say, like 50x in the middle of this crisis. It is amazing how many vendors I'm just getting deluged with. Vendors claiming they've already developed AI solutions to triaging your COVID patients, knowing which ones are going to get sicker, how to put them on the floor, don't let them in the ED, which ones are going to end up in the ICU in the next 30 seconds or 72 hours, ones that say that they can tell from a chest x-ray who's got COVID. And all these things are kind of amazing because being in the middle of this, I can tell you that none of that is even conceivably possible, the level of precision that they're all talking about. But when you're in a much smaller practice, you don't have the time to do those kinds of validations. So long way to say, I think there are a couple of things. One is one of the great tells of how good a vendor is going to be is when you meet with them, you got to kind of get past the initial salesperson speak. But then when you meet with their people who are really principal in the organization, if they start the conversations with, I came from the consumer business, I came from the investing business, I came from the fintech business, and this is the way we do it. So if you guys just catch up to us, everything will be great. You should run away from them shrieking if they're going to be a core part of your patient flow. They might have some useful play if you're looking at doing a new financial modeling or you're trying to grow your business in a different way. But for core pieces of your patient care delivery, you've got to work with vendors who've been in the space and fundamentally understand the science and understand the flows of patient care delivery. So I'm not saying you got to work with one of the old guard companies who's been in the space for a long time because they move too slowly and they deliver too slowly. But you need to interview these companies very carefully and make sure they understand the underpinnings of what you're working with, because it just doesn't work when they don't really understand it and they're here to disrupt you, not to transform your business, but they're here to disrupt your business. I'm not sure that coming out of this, people are going to have much appetite or ability to tolerate a whole lot more disruption than we're having right now. So that's one of the things we spend the most time is how much are they able to tolerate the pace of healthcare and how much can they move us faster without telling us that we just need to go break everything in the store.
Yeah, in a session I gave earlier, there was a great paper in HBR talking about the digital evolution that should be it should be a way to get to a future state, but it doesn't have to disrupt your current processes. You just simply amplify them and help with where it can and plug them in. But it's not like a complete disruption, or it shouldn't. If you do that, you're going to get in more trouble than you expect.
Yeah. There's one other point to make in there, Stefano, is also don't get sucked into the allure of all these things have to be incredibly cool, powerful, clinical, apps. There's a tremendous amount of value and there's a tremendous amount of waste that we have in just the back office activities and in the patient flow activities. As much as many of the smaller practices have become more efficient, there's still huge opportunity. We've taken a huge amount of the cost of running the practice out just by doing things like automating faxing, things like that, and doing OCR and faxing, and silly little mundane things take a huge bite out of it. So look all across the practice. Self-scheduling is obviously incredibly important. More things you can push out to the patients, looking at things. How can they report their incomes? How can they their outcomes? How can they fill things out online? So you can take some of that administrative burden out. Those are, from a practice efficiency standpoint, much better than some really cool algorithm that tells you something right while you're trying to manage a patient.
Yeah, I was just thinking about our current pilot with Luma, which is a clinic referral management tool. The number of calls that has taken off our back office simply because the software reaches out to the patients and connects with them who want an appointment seems banal until you start doing the math, which we're in the process of doing. We looked at a year's worth of data. When I calculated the cost savings based on just freeing up our staff from trying to find people to book an appointment, is all automated.
Right. These days, no one answers the phone anymore, right? So it's like people who were doing robocalls using old technologies like, Televox. They're like, oh, we contact everyone before their appointment. We make sure they're going to show up. I'm like, no, you don't. You leave a voicemail at their home, which they never check, right? No one ever does that stuff, right? So you got to get to people's current technologies. And you free up the front desk staff, and you free them up even more by getting patients to use tablets in the office and not to have to, re-register people all the time. All of those things become huge savings, which improve the patient flow, cost of running the office, and patient satisfaction.
Let's pivot a little bit to leadership. How important has it been to your success to have the government association, the organization behind you at your back, supporting your vision and your ambitions, if you will?
So you can't
alignment. I'm looking for is alignment critical to success.
Yeah. So it absolutely is critical. You can make some progress trying to do this quietly by yourself, but particularly in a big organization, you run into too many barriers and everyone having their own way of doing things and a lot of resistance because this is just the way we do it. We don't really want to change. Many people don't see the reason we need to change. Even if leadership is really espousing, hey, it's time to change, we need to change. The big organizations are so many people that anyone can veto a change that you're trying to put in. So getting that alignment and continuing to drive that through is critically important. I think in smaller practices, it's somewhat easier because there's a much better or a closer relationship between leadership and the people who are doing the work. But the alignment is still critical. If you have a small number of people who are not on board with significant change, it becomes that. I mean, this is all change management 101, right? Knowing who your supporters are, knowing who your detractors are, knowing who's going to be neutral about it, and really doing the work to find the detractors. Because even in a moderate-sized practice, someone who's working to subvert the process will always mess up even the best plans.
Right. Yeah, and that's absolutely critical. Tell me about. Let's say you've got the leadership to support you, you've got the vision implemented. What recommendation would you have to somebody who's trying to put in place a new technological solution and the challenges they may have in leading that change? How much resource needs to be applied to, and how to apply that resource or those resources to enabling that change and ensuring its success?
So some of the estimates are that the change management activity that goes along with any implementation is around half of the effort. You can't spend the majority of it on your technology, on your stack, on your software, and then leave a little bit for training or a little bit for change management. You've got to do, and using a lot of the lean methodology, working with the people who are in the practice, in the workflows, having them identify where the problems are going to be, having them come up with solutions, being part of the ideation, really gets you a lot further along in the change management because you've got them, on the side of the change instead of obstructing it. I think that's the surest way to have failures or to prolong the time until the thing can be considered successful is underselling the change management in it.
Yeah, there was a company that in their contract they were suggesting to us 2 weeks of support. I'm like, no, that's not going to work. You're going to have to stick around longer than 2 weeks until we're going to be able to ensure that this product works as we go through with it. I think you gave us a really good insight into how somebody working within a healthcare system can work with an organization to create a product that could then be leveraged and sold out and create income to the university. That was very well discussed. What I wanted to, just in the last couple of minutes, the idea of, I think you mentioned this idea of the patient journey, understanding the importance of the product-based thinking. It's very different. You described it already, but I think it's worth repeating. It's like we used to look at it this way.
Yeah.
When you think about it from the patient's perspective and their experiences as they go through it, has that been a useful methodology by which to bring everybody on board so they all look at it from the same perspective and looking to get to the same outcome?
So there are two pieces to that. The one which you were just touching on is that the language around it is incredibly important. People who work in our environment, they might be attached to the ways they do things and they might not want to change. But when you start talking about it from the patient's perspective and the patient's experience, but the reason they work in our environments is because they care about those things, right? There's very little that's more important to them than how the patient does. And so it takes out the us versus them, the I want this and they want that. It gets to, hey, we're all here for the patient to make the patient's experience better, to make their health, more pervasive and to really take care of how they're feeling, not so much how we're feeling things. And then if we work together, we can create an experience which is great for the patient and better for us at the same time. So you can start to really get people more. So an example is you think of things, chronic disease management, or if you're thinking about something like hospital at home, which are two big efforts right now, right? The old model would have been, we would have sent someone a blood pressure cuff and a pulse oximeter to just monitor themselves at home and tell them to then go to the EHR portal and enter their data in, right? So you're just sending this thing, they're getting a box, and then they're supposed to figure out how to work it, and then they're supposed to do something, and then they're supposed to enter some vital signs in. And then the doctor is then supposed to go know that happened miraculously, or they get messaged completely out of context that there's some data waiting for them, and they're going to go search that. That's the old way of doing it. None of that worked. If you start from, again, the user-centered design, you said, okay, you have a sick person, you got to educate them about their disease, educate them why these pieces are important, and say, okay, now you're going to get this device, and here's how it's going to connect you to your care team, not necessarily your doctor directly, to your care team. And this data, they're going to respond to it, they're going to work with you around it, and if anything important happens, it's going to get to your doctor, and your doctor is going to tell everyone what to do. So when you create that whole user journey, and that's part of when you'll be coming to the office, when you don't need to come to the office anymore because we're monitoring you remotely, creates a much better story that's much more efficient for everybody all the way around.
Excuse me, I apologize. Let me ask you a little bit about what, we got 10 more minutes, and you're going to go back to work, probably your workday is not done yet. What are the top 3 things that you're looking to move forward in the next, say, 2 weeks to get us ready for COVID-19 specifically? Because we are now probably, we're not quite past the curve yet. So what are you thinking? What are the top strategic priorities for you as CDHI at UCSF that you're dealing with and trying to push through?
Yeah, so there are a couple pieces there. One is, really right in front of us is the COVID positive patients who aren't in the hospital. How are we going to monitor them? How are we going to track them? How are we going to know when they're recovering versus when they're getting sicker and do need to get into the hospital? And what are the data points that we can use, and what are the biomarkers we can use to figure out when someone really needs to be hospitalized and is going to benefit from it. So a lot of that is technologies that we already have around patient-reported outcomes. Some of it are things we need to do much better with remote devices and hospital to home that I was just talking about. So getting those pieces up very, very quickly without having the luxury of building a whole new program around it, a whole new product around it, is creating a lot, some significant stress right now. We're probably, to be honest, not going to have the luxury of building it like we would want to build it because there are already accumulating patients out there who need to be monitored now. So we'll, we'll fake it till we make it a little bit for the, first couple of weeks while we're building the longer term solution in the background, and choosing the vendor and choosing exactly what the flows will be like. Going past that is leveraging that experience into much better hospital at home and chronic care management in a more durable way and in a more scalable way. Scale is going to be huge here, because we're going to see far more rapid changes in what the expectations and the needs are in the community than we've probably seen ever in our experience in healthcare anyway.
Specifically, you're referring to chronic care management and pushing that outside into the home, you mean?
Yeah, I mean, so we've talked forever about we're out of capacity. We've got to get these patients out. We're really going to be out of capacity now, and we have to get, we're going to have to deliver more care. So I think if you look at it like care per unit time, we're going to have to be delivering a much higher intensity of care than we've delivered ever. Yet our physical footprint isn't really changing that much. So that's going to be one of the challenges. Well, the other challenge that I think everyone's going to be running into is budget. We have no insight yet into what the finances are going to look like or how much federal bailouts will help. But one thing is that all of the patients that we make our money off of haven't been coming to the hospital for the last 2 months, right, or a month and a half. So the budgets are going to be challenging, and in the setting of very challenged finances, we're going to have to be investing significantly to put these new technologies in place. And that was we were talking before we went on around how do you make the choice to invest in things in the middle of a crisis. And I was relating that, I heard a great talk by John Chambers, who used to be the CEO of Cisco, who said that during the dot-com bubble and when it burst and everyone was going crazy in Silicon Valley about, what are we going to do? He used that as an opportunity to go around and make big investments and buy a lot of companies, so that when he came out of, he knew that this would eventually unwind, and when he came out of it, Cisco came out as one of the global leaders, and that was what really cemented them as one of the global network leaders in the world. So I think it's important to think of it like that. When you're in the darkest of times and you can't imagine getting any money, you can't imagine how you're going to be able to put new technologies in, those are the times you actually have to be doing it. It's most important to do it, so that when you come out with a very solid footing and you're able to accelerate, instead of saying, okay, now the problem is really crushing me and I can't do anything about it.
Right. And you don't have the tools with which to manage it.
Exactly.
Two questions we'd like to get to. One, actually, another question we're talking about as we're getting ready in the green room is this idea of platform. And not viewing the EMR as the entry point for technology, but rather to create a middleware solution into which multiple apps can plug into, and the middleware is the only conduit to the EMR for its true data. Would you talk about that a little bit?
Yeah, I think that's exactly right. I think that the EHR, we spent a huge amount of treasure putting our EHRs in, and we've, put a lot of burden on our clinicians to populate the EHRs and the whole care team to populate the EHRs. And they're a critically important workflow engine and a critically important data source, but they're certainly not the totality of the patient experience, and they don't contain all the data. And more, as care is getting more complex, genomic data, things like that, are rarely in a meaningful way in the EHR. It's very obvious that you need, systems of record, which is a lot of what the EHR is, but then you need systems of experience and systems of engagement. And those are three different layers, and you need all three layers for things to work, and they need to be interconnected in a seamless way. So that's to your point of, you need integration engines, you need an integration layer. All of the sensors that are out should not be connecting directly to the EHR. They ought to be connecting to integration levels. And then a lot of times you're going to need to run analytics on that data that's acquired by these external sensors to decide what needs to go into the EHR. Spurious data, some data needs to be acted on immediately, and it needs a different methodology of going through or going around the EHR depending on how you have it set up. We would always want any critical piece of data to enter into the EHR and to be there recorded and hopefully kicking off a sequence of care. But sometimes it also needs to go to the provider's, mobile immediately. So you need that whole integration level or engagement level where you can where you can act as you would. And a lot of the EHR technology is not built to really support that innately, so you got to build around it.
Yeah. One last question, then I'm going to try to wrap it up and contextualize this for orthopedic surgeons that may be watching this and to understand how does this apply to me. And I think that there's a lot of which applies. But Mike Ryan's asking, are you benchmarking with other academic medical centers on how you're dealing with COVID-19, but especially for technology? Is there communication amongst, I know about the UCs are communicating, but the question is it also outside of UC?
Yeah, we're talking to colleagues around the country, both to get a sense of how they're doing in general with clinical care delivery, and especially in New York, where they're suffering tremendously, to really keep ahead of things, and trying to learn from them as much as we can. We talk to folks, the other UCs and other care providers around how we can share tools, how we can share learnings and protocols that have been developed. We're also sharing, all the way to sharing PPE with them. So if we have more of something, getting it to them if they have more. I think we've been fortunate in the Bay Area. We haven't gotten really creamed yet by this thing. Everyone's hoping it'll stay that way, but everyone trying to hang in there and do everything they can to keep everyone afloat right now is super important. So answer your questions. Yes, we're talking to everyone around the country, finding out what we can learn from them, figuring out where we can help and where we can help others.
Mike, that was, I think, an amazing overview of what the work is that has to be done at your level in organization. I think you gave us insight into the complexity of doing a system-wide deployment of technology and how it can actually be done once you achieve alignment and you have the right methodologies to do it. Some of these new methods that came out of programming and computer science now applied to the way we do business to turn things around quickly and effectively. You give advice to small practices that may not have these very large teams in place to put in place, but they also have smaller challenges. And one suggestion I might add to the group is even if you have a small group, you can identify a person in your team who take lead on these things, become an expert. Like I have had the opportunity to do for our department, and Einar Shore as well is also in our group, also has that technology skill, and that allows us to allow one small group. We're a mini CDHI within the department, and other groups can think about doing something analogous. We talked at length about design thinking and its impact on how we can bring people together around the patient experience as opposed to people going to their beliefs and habits, if you will, around project. So with that, I'll call us an end. Can I thank you again, Mike? That was phenomenal, Michael.
It was my pleasure. Hope it was helpful to everyone, and wish everyone the best.
Thank you very much, everybody. Stay safe, wash hands. Don't do what I do, cough hands. Terrible. Thank you, everybody. Take care now.
Take care. Good to bye-bye.